isolation, when he talks about pec minus being tight, you're adopting this poor position when you've got this particular biomechanical problem. He said, right, I want everybody to adopt this position. Only 50% of people actually move. Did you notice that? Room experts, great. So Rich has asked me to talk a little bit about functional training, functional movement, and how that relates to sort of a sports type context. So loosely, that's what we're going to be talking about. I've got a couple of questions I'm going to ask, and we're going to work through what we think are the answers, or at least some of the considerations we should think about. And then we've got 3 case studies that we're going to talk about at the end, and how the whole biomechanics piece links with their particular presentation. So these are some of the guys that over the years have used the sort of intrinsic biomechanical principles. You'll recognise some of them. The England rugby team was the 03 team, not the rubbish that you're seeing at the moment. And we're going to be speaking in some of the case studies. Going to be about golf and boxing and rowing, so we'll pull those in as well. So these are some of the guys in the past that have used the sort of intrinsic biomechanical process. So these are the questions we're going to talk about this morning. We're going to talk about isolation versus functional training. What's best? Is there a place for both? Is the abnormal movement causing the pain, or is the pain causing the abnormal movement? It's a fundamental question, and if we don't get the answers to that right, we probably won't be able to manage our lives as well as we like to. So it's a fundamental question we need to understand. And then we've got some case studies. We've got one on golf, rowing, and boxing, as I say. So that's what we're going to be talking about. What we're not going to be doing is telling you what to think. What we're going to be doing is we're going to try and make suggestions on how to think. Because you guys are already qualified. You're already experts in your own field. What we're doing is throwing ideas around that might help with the process. So it's more about how to think rather than what to think. And that theme is going to go throughout the whole of the day. James has started that off already. This is what you've got to do, these are some suggestions, and then you try and figure out how to integrate it into what you're already doing. So, question 1, isolation versus functional training. Should we train the movement, not the muscle? Is movement training ever wrong? And is the same movement pattern right for everybody? We're all going to have our views on that, but probably will be different. So what is function? Well, some people think that sort of stuff is functional. Some people think that stuff is functional. And then we've got all this stuff going on in our clubs and gyms and in the parks and gardens, and some people think that that's functional as well. There are some people, this guy's following, there's quite a lot of evidence to suggest that that's probably a good thing to do in certain circumstances. Some people are suggesting that that's functional too. But let's be honest, most of us sit down doing this all day. So, if functional training is about preparing us for the task that we're about to perform during the day, maybe our gym should be full of typewriters with weights on the end of strings. Probably not, but you get the idea. We need to really understand what on earth functional is, and we're going to talk to that a little bit in a minute. We think it's probably important to synchronise the exercise. The sequential nature with which we prescribe exercise is probably very important. And there sits the isolation functional piece, as we're going to drill into it in a moment. We would suggest you probably want to fix the problem first, isolate the problem, before we start doing functional type stuff. Otherwise, we're just learning to compensate for the biomechanical problems. I'm sure you can see the logic of that. We're going to drill into that in a little bit more detail in a second. Anybody see one of those? It's a knee replacement, total knee replacement. This is a particular interest of mine at the moment. I'm working with a company that designs the implants themselves. So we're looking at how we can biomechanically improve the design of the implant so that they last longer, because they don't last very long at the moment, of course. And when I went into, I was explaining to Kat earlier, when I went into the lab when I first saw them a few years ago, these guys, the 3D analysis that these guys were doing on the implants just blew me away. I was sitting there thinking, oh, they've asked me in as a consultant. I don't know what they're talking about. What they didn't know about knee implant design wasn't worth knowing. But it's only when you drill into them a little bit more deeply that you realise that they don't know anything about the rest of the body. They know the knee inside out, their hip inside out. But you speak to them about how you can do some work on the shoulder biomechanics, which impacts upon pelvic function, which then impacts upon how the knee functions and the hip functions that look at you sideways. So that's a piece of work which is actually quite interesting. But the point of the slide, sorry I digress, but you'll find that different a little bit. The point of the slide is to say, would you do functional exercise with this guy? Absolutely not. Would you fix the problem first before you started doing functional work? Yes, of course you would. Fix the problem before you started doing anything functional. ACL reconstruction. So that's a bit traffic fine. I couldn't find anything more gory, I'm afraid. So ACL reconstruction. Would you do functional training with this person? Of course not. You'd fix the problem first. Different kettle of fish, right? Healthy lady. She comes into your facility. She's done the PARQ. No problems at all. Past medical history, nothing to speak of. I went on a TRX course last weekend. Guess what she's going to get this morning? She's going to get functional training. I went on a gym ball course the other weekend, the previous weekend. She's going to get some gym ball work. Functional training with this type of work we're likely to do with this lady, depending on her goals and aims. But when we then screen her, we might typically see something like this. We might see problems biomechanically with the left shoulder, problems biomechanically with the right QL. Left side of the pelvis is dominant, left knee is dominant, she's got a problem compensating with the foot. Whether it's the foot causing that or that causing the foot, whether it's ascending or descending, who knows at the moment. But fundamentally, she's got some quite significant biomechanical problems. Are we going to go straight to functional training with her, or are we going to fix the problems? Chances are, we're going to fix the problems. Otherwise, all we're doing is teaching people to compensate for their biomechanical issues. And that's one of the reasons why we see so many abnormal movements, is because they're having to compensate for this type of problem. Preaching to the converted. We just want to make sure that we're on the same page. Here's another example. Have you heard of Derek Redmond? Do you remember this guy? He was a 400-metre sprinter back in the day at the Barcelona Olympics, 1994, I think it was. And this happened.
Derek Redmond, in the best form he's shown since he broke the British record.
He was in great shape, you know, he had a chance, possibility of maybe getting a medal there.
Redmond doing a match, and so too in lane number 3 is Steve Lewis, but Redmond's gone very close indeed, and so too is this guy, Haines. Down the extra, he's the national leader. Father of Nigeria has gone very quickly, and Redmond has broken down. He's on the track, kneeling down, and Derek Redmond, on his injury problem, the jinx has struck again.
Running down the back straight, I had a funny clap or a pop, and I honestly, for a split second, thought a big shot. And then obviously everyone knows I thought a hamstring. And then when the pain sort of died down, I remember where I was and I was doing it. I was like, you're in a different semi-final, you try to get up and start running. And I got to the 200 metre mark after holding 50 metres. I looked across all the guys and finished, and it pretty much hit me that, you know, it's all over.
I relate it to what it is. No way I would have done that, because when you got a hamstring, you know you got a hamstring.
He just wants to finish. His dad's trying to run under the track to stop him. He's going to tell him, Derek, go.
The old man went to put his arms around me, and I was just about to try and push him off because I thought it was something else. I didn't see him sort of jog from behind. And he said, "Let me do this, you can stop it now. Yeah, but nothing's proved." And I said, "Oh, I haven't get back into lane 5, I want to finish."
Now in the greatest arena in sport, he's getting the chair of the games.
I would never wanted to be in Derek Shoe at that time. It was a sad moment. It was a great moment. In the sport.
It's a figure, a picture that just stays in your mind forever, because you don't want to see any athlete have to go through that. You just knew how destroyed he was and just how much that race meant to him.
Don't feel too sorry for him. He's making a fortune on the after-dinner circuit now, showing that video. Derek at the time was known as one of the best extrinsic components of running. His technique was absolutely superb. The Americans were studying how he ran to to try and mimic that from an extrinsic biomechanical technique. Intrinsically biomechanically, he was flawed. He had a problem with his pelvis, he had a problem with his shoulder, and this was in the day where we were just developing the programs. But in those days, even those days, we knew he had a biomechanical problem with his pelvis. And what had happened is, in those days, they didn't have the fancy facilities that they have now. In 92, he was in a bunk bed, student accommodation, you know what that's like, some of you. Fundamentally what had happened is pelvis had rotated because he was sleeping in these awful beds. There were probably other reasons as well. As his pelvis had rotated, piriformis had gone into spasm. As you know, piriformis is closely linked with the sciatic nerve. The sciatic nerve was tensioned halfway down the back straight, which is where you sprint the quickest. Hamstring went into spasm to protect his sciatic nerve. Fundamentally, all we did with this guy, he didn't tear a hamstring. His hamstring was fine. He flew back to see us 3 days later, and he had these biomechanical issues. And we showed him a bit of this, free the pelvis, a little bit of sciatic nerve mobilizations, a bit of slap and tickle on his hamstring to make him feel better, massage that is. He was sprinting 10 days later. Anybody had a hamstring problem? Were you sprinting 10 days after you did it? If it was one of those big pains, it could be 2 months, it could be 3 months. If I rehab you, it would probably be 4 months. It takes a long time. It takes a long time. 10 days. It wasn't a hamstring problem. The problem was a pelvic problem causing the tension to his sciatic nerve and the hamstring rotator. So you can have people, you can have people that are extrinsically really good, they're moving really well, but they still have fundamental problems. So we can't just look at the way they move to identify whether they're potentially a problem. If we just take a moment, this is based on some of Charlotte's work in the therapy field. Have we got any therapists in here? No? So in the therapy field, there's been 4 distinct areas over the last 60 years. Initially, therapists were trained to how to manage dysfunction of the peripheral neuromuscular system, so polio. There was a load of polio around 60 years ago, so as therapists we needed to figure out how we were going to manage that. And then the predominant dysfunction was neurological problems, muscular MS, strokes, people with these types of problems. So we needed to be educated on how we manage these types of problems. Then, probably 20 odd years ago, we had a bit more time on our hands, we started to a little bit more leisure, we started to get a bit more into sport, we started breaking. We started to get musculoskeletal type problems. So the therapy training had to be evolved, so it was more related to joint dysfunctional work, and now more recently we have this movement system or movement approach work. And this is how we tend to approach things these days. The trouble is, because the training has evolved based on these types of issues, somebody comes into your clinic or your facility with polio as a therapist, you've forgotten what to do because you're not trained that to it anymore. Thankfully it doesn't have very much. But with MS and strokes and things like this, it's not a focus of what we do anymore. The problem is, we've kind of thrown the baby away with the bathwater. What we need to be thinking of is how on earth we can retain some of the education from before and progress through and integrate it into the new learnings. And in fitness it's the same. It started off 60 odd years ago with calisthenics. You see them on black and white videos on YouTube. It's all calisthenics, all this sort of remedial gymnast type stuff, which is great. And then of course it came into bodybuilding. Arnie started to get more famous and people were getting into the bodybuilding stuff. Very isolatory when it comes to exercise. It was right at the time. And then of course we're much more sophisticated now. We do this functional stuff. Much more sophisticated, much more sexy. But again, we're in danger of throwing the baby away with the bathwater. Some isolation work still has its place. Depends on the goal of that individual. And let's be honest, the calisthenics is just basically circuit training and a bit of aerobics, right? We've just rebranded it. It's the same stuff. So we don't want to make the same mistakes that therapists have made and move on and forget the stuff from the past. Because it all has a relevance. We need to build on what we did know to what we do know and integrate it together, we would suggest. So when we look at functional, I must admit, I'm still not 100% certain what it is. You listen to 10 different American gurus, and they'll give you 10 different definitions of what it is. So I'm not entirely sure functional is the right way we should be describing. I wonder whether we should just be using movement. There'll be some smart PR people that come up with much better ways of doing it than that. Is it relevant movement? Is it optimal? Personalised? Specific? Who knows? Who knows? Who knows? But maybe the term functional, because it's so vague and at the same time so very, very specific for each individual, maybe we should be thinking of a different way of different terminology for this. But in terms of the sequencing, as James spoke of before, we're not going to drill into this in too much detail. What we're talking about in terms of the process, M for muscle release, provide the muscle with the capacity to be able to engage, and then S, stretch, should we need to be able to do that, and then do some antagonist work to look at the muscle imbalance, to try and make sure that that is eradicated as best we can, and then of course the conditioning side of things, and how we progress, whether we go from isolated to integrated, whether we go from open chain to closed chain. It depends on the individual and your background and your expertise. But that's the sort of system in terms of the sequencing that we're talking about. So it probably shouldn't be isolation versus functional training. It's potentially part of a sequence. So the preparation for movement, you might suggest then, is isolatory. So for example, we might do something like this to release the spasm in the hip rotators if we feel there's a problem with the biomechanics of the pelvis. And some of you will be familiar with that. We might stretch. Glutes, piriformis, whatever you think that's stretching, we might do a bit of stretching. It's isolation. Do we do these exercises anymore? Well, if you listen to our American friends, you should never do this stuff because it's bad, it's isolation, well, you should never do that. But what if you had a piriformis that's been in spasm? And of course, you could pick any example, but let's go with piriformis. Piriformis, one of the things it does with the hip at 90 at 45 degrees is the hip abductor. Do we want to work the antagonist to that? If we're trying to go through the MSAC process, we probably do. That's a pretty good way of doing it. Do we want to isolate? Absolutely, we want to isolate. We want to make sure in this phase, chances are, they don't have the capacity to be able to use their core muscles, whatever they are, their core muscles to be able to stabilise. So we might want some artificial support initially. We might not do this forever, but for a period of time, it's probably a good idea. So do some antagonist work and then some agonist work. Once the muscle has the full capacity and the joint is biomechanically sound, we can do all the fancy stuff we want, no problem at all. But we might use isolation exercises to prepare that individual prior to starting all the fancy stuff. That would be one suggestion. Do we do seated leg curls? We'll do it technically. Probably a good idea. If somebody is quad dominant, and the hamstrings are down in relation to the quads, it's probably a good idea to build the hamstrings up. And it's probably therefore a good idea to isolate. Because if we're just going to continue to do functional work, dynamic type stuff, using 3 joints, squatting type work, and there's a muscle imbalance now, if we're working everything the same, it's going to continue to be out of balance. So we probably want to isolate one area to bring the balance up, improve the balance, and then start doing the functional stuff thereafter. Is there a place for this? Yes, of course there's a place for this. Is it functional? Probably not. Does it matter? No, it doesn't. We don't have the capacity to kind of engage Transam prior to different activities. All the work from Hodges Richardson from years and years and years ago suggests it's probably a good idea to do. And then we can start doing all this fancy stuff and make sure that they get injured so we get a bit more business, right? Let's just take a little bit of time to look at the movement screen. We're all familiar with basic movement screening, right? There's a million out there. Performance matrix, functional movement screening, there's a load. And they're basically around these 7 movements, right? So when we look at break these movements down, let's just see what planes of movement we're working in. The push basically is in the sagittal plane, this type of activity. Pull is basically in the sagittal plane. Squat is basically in the sagittal plane. You see where I'm going with this? Lunge is in the sagittal plane. Bend is in the sagittal plane. When we twist, transverse, and combo, depending on which one you use, is a variety. There's a big flaw in most of the movement screening out there at the moment because certainly in the FMS, there's no foot placement. One of the things that we're developing as a group is how we then look at improving this system. I do believe that Gray Cook is very, very misunderstood. When you listen to his disciples, I think what happens is that his information gets so watered down so as to be, in some context, flawed. But when you actually hear from the horse's mouth, he's got some really good ideas, some really nice ways of describing what the FMS does. And when you listen to him speak, he'll be the first person to say, well, actually, this is just something for here and now. He's actually waiting for a group of people to take that on and improve it and try and sort of for the greater good, so to speak. So he seems to have a really good attitude and spirit. I've met him a couple of times. Nice chap. But fundamentally, if we're going to be performing a movement screen, we don't have any function plane in that particular one. So as we develop as a group, as we start to move forward, educationally and professionally, we probably want to bear that in mind when we start to develop different things. I'm working with Mike Grice, Anthony Fletcher and Ray to look at how we might create our own movement screen. At the moment we've got it down to 3 movements. Once we've nailed it, not that we're going to get close, then we'll start to share it. Maybe this time next year we'll start talking about how that's looking, and then we can share ideas. So just something to note, really. So, is question 1 answered? Isolation versus functional training? Well, it probably shouldn't be versus. They both have their own role to play at different times. Should we train movement, not muscle? Sometimes. But actually, sometimes we should train muscle. Is movement training ever wrong? Yeah, absolutely. Of course it is. And is the same movement pattern right for everyone? No. It depends on their intrinsic biomechanics and anatomical factors and a number of other things as to how we should be training these guys. The same pattern mustn't be the same for everybody. You've only got to look at golf swings, which we'll talk about in a moment. So, that's question 1. Question 2. Is the abnormal movement causing the pain, or is the pain causing the abnormal movement? How do we know? And how does this influence our exercise prescription? So this is the next piece we're going to cover. So, the relevant factors. We've got behaviours, which are movement patterns. So technically we refer to those as behaviours. And they could be either compensatory or they could be protective. Then we've got interventions, so things like exercise, therapy, surgery, and there's a load of other things that we might use. And then we've got the cause. The cause could be biomechanical, neuromuscular, physiological, it could be pain. And all of these 3 factors, they kind of work together. Then there's a lady called Shirley Sharma, who's an Australian therapist, who came up with this really cool model of how movement affects pain and pain affects movement. And then what I've done is work with Grice, Fletcher, Rach to look at how we can integrate that into a system that is understandable. She's so smart, this woman, and when she speaks, really clever. I have no idea what else she's talking about. So we've tried to put it into a simple system that even we can understand. So let's start with a structural problem. So let's say somebody's busted ACL, or they've got a cartilage problem, they have a structural problem. As a consequence of that, the body remodels the way it works, the soft tissues remodel, and we move differently. And the way we move is a protective pattern. So once you've damaged your knee, you'll live. So it's a protective pattern. And then you produce that movement repeatedly over time, until either the problem heals or you get it fixed. On the other side of the spectrum, you've got functional problems. So let's think of a functional problem, weak glutes, for example. We can talk about the merit of weak glutes in the bar later if you like. But let's say it's a functional problem like that. There's a load of adaptation because you'll be limping, you'll be moving differently to compensate for that. And the movement pattern is a compensatory pattern. Rather than a protective pattern, it's a compensatory pattern. And again, you produce that repeatedly. So you've got 2 different strands. Either it's a structural strand or a functional strand. But of course, once you get to here, a compensation movement pattern could very easily cause a structural problem. You could be moving so badly that you start to damage or load your ACL, for example. And equally, over the other side of the spectrum here, a protection pattern could then start up a functional problem. And then you have this vicious circle. And the key is to figure out, okay, so how on earth, in this cycle, do I know where to impact my exercise prescription? What do I do? And how do I know where to do it? Well, let's just break it down a little bit further. This top bit is referred to as the pathokinesiology model. In other words, the pathology of the injury causes the way we move. Then we have the exact opposite down here. It's the kinesiopathology model, where the movement affects the injury, or causes the injury. So those are the two different models that we have here. If we look at the different pathologies, we can see there are two types of pathology. We've got structural or we've got functional. And then when we look at the remodelling, we could say that we're actually adapting. So we're adapting the way we move, we're adapting the way we're compensating for these particular problems. And then we've got the different movement patterns. So we've got a protective pattern and we've got a compensation pattern. So you can see how the three play absolutely into each other. So, when it comes to the pathology, we need to do a clinical screen. We need to be able to diagnostically establish what's going on with that particular individual. If you're a therapist, that's great, because you have the skills to do that sometimes. If you're in the fitness industry, you send them somewhere and you get that information. That's all good, no problems. So the clinical screen will identify the pathological problem. When we're looking at the remodelling, or specifically the adaptation, that's where the biomechanical screen fits in, because that will tell us how the body is compensating. Irrespective of whether it's a pain compensation pattern or a protective compensation pattern, this will tell us how the body is recoding itself to be able to move around whatever the problems are. And then we've got the movement screening, and its place is here because we're looking at the movement patterns and we're looking at protection and compensation patterns, and the movement screening fits in there. So that's kind of how it all works together. Does that make sense? Okay. The problem then is if we just did a movement screen, we wouldn't really know whether that abnormal movement was a compensation or a protection pattern. We have no idea. And if it's a protection pattern, and we identify we're doing an overhead squat, that knee's going into valgus, that knee's coming across, and it's a protection pattern, and then we change it because we're going to give them a bunch of exercises to strengthen the muscles here, to straighten and realign that leg, there's a reasonable chance we're going to hurt these people. So it's potentially quite dangerous to change the way we move until we know why we're moving like that. That's the point. However, if we just change the adaptations, we change the sequencing, we change the coding of how the system works, we reduce the risk of hurting people. Because all we're doing is giving them the capacity to move how they want to move. Does that make sense? Yeah? Okay. So, in effect, that's the pathomechanics of movement, and we need to understand where our people are up there. And the safest way is by working in here, changing the way the body is remodeled to give it the capacity to be able to move the way it was intended to move, rather than artificially forcing it to move it in a theoretically correct way, which actually may not suit that individual. That is a risk. Okay, I feel some questions going on that later, which is all good. So let's have a look at the intervention sequencing. So we've got movements that we do every day. These movements are performed daily. The different movement pillars, the principal movements that enable power movements. And then we've got the biomechanical profile over here, which provides the capacity of the relevant structures to deliver whatever those movement pillars are. But normally that's the sequence that things happen at the moment. What we're suggesting is the biomechanical profile should probably come into the learning. Once we understand this individual, to then screen them to identify what specifically is going on with them before we allow them to do a load of movements is probably going to reduce the risk. Mike did a presentation at the IOC last year, I think it was, and talked specifically to this and how we can screen the biomechanical profile specifically in that presentation to look at lumbar pelvic movements and the risk of injury as a consequence of that. And it was very, very well received. So I think we're going to get some of that later on. So, when we look at the pathokinesiology model, the first thing we need to do, because the pathology is the problem, the injury is the problem, chances are we're going to want to fix the injuries. So you send them to whoever's appropriate that you know. Once the injury is fixed, then we might look at the adaptations, and we'll look at how we're going to change the coding of the sequencing of these muscle interactions, and then we might do some movement work. That's all fairly straightforward, I think, and reasonably well accepted. After 6 weeks, of course, that changes, because after 6 weeks, if you've got a problem with your facet joint, for example, in your back, and then you've been moving for 6 weeks abnormally, there's a reasonable chance you're going to start getting disc problems. And if you have disc problems for 6 weeks, there's a reasonable chance you're going to start getting neurological problems. The body will adapt and compensate. So it changes. Invariably, we have found, working on the biomechanics initially, in those situations, pathokinesiology after 6 weeks, sort the biomechanics out first, and more often than not, you don't need to fix the injury. Because after 6 weeks, unless it's something that's going to need surgery, after 6 weeks, they often settle down. How many times do you tweak a back, tweak a hamstring? Give it enough rest, I don't think it'll go away, right? It doesn't always need treatment. But if it does, the next thing to do is sort the pathology out and then start looking at those corrective patterns, look at the adaptations from a movement point of view afterwards. So after 6 weeks, things change. And I'm pretty sure, is Rachel there, are we emailing the notes to the guys afterwards? Yes. After the event. So you're going to get all this stuff, so don't worry too much about making those. For the kinesiopathology model, we probably still want to work the biomechanics first. Because remember we talked about earlier, if we start to change the way they move, even though it's the movement that's causing the problem, if it's a protection pattern, changing the way they move, it might hurt because they need to move that way to protect a particular problem. So we might want to change the adaptations first, and then look at the movement, so they have the capacity to do that movement in a proper way, and then work on the pathology afterwards, if necessary. More often than not, you fix the mechanical factors, you fix the way they move, and the problem usually goes away from a pain point of view. So it's distinctly different approaches depending on whether it's one or other pathokinesiology or kinesiopathology. So when we look at dysfunction, we need to figure out whether it's the body causing the movement problem or the movement causing the body problem. Fundamentally, that's what we need to do. If you're working on a one-to-one basis, you've got time to look at the body and identify whether that's a high risk for the movement. If you haven't, and you're working in groups, then you don't have time to work on the body individually, more often than not. So that's where the movement screening really comes in well. You can get 20 people doing an overhead squat, and very quickly you can see whether they're bending forwards. So I'm doing that to Rachel, where is she? Very quickly you can see whether they're bending forwards or whether their knees going valgus. You're immediately flagging the high risk guys, you pull them out, and then you do the biomechanical screen on them. So it depends on your environment as to whether you go with the movement environment or the movement screening, or whether it's the individual biomechanics. This we know as intrinsic biomechanics, this we know as extrinsic. So they both have a place. There is no right or wrong, it's identifying which is right for your people and the environment that you're in. But they each help each other as you move forward. So, question 2 answered, question mark. Is the abnormal movement causing the pain, or is the pain causing the abnormal movement? We have no idea. We have no idea. How do we know? We don't. How does this influence our exercise interventions? How does this influence our exercise interventions? Absolutely it influences it, but we don't really know. You go to see a therapist, they don't really know which came first. So the safe way to do it is to sort the biomechanics out first. So, sports examples. Golf, rowing and boxing. These are some of the people that I've seen. The variety of sports movements that exist represents the many ways that the human body can compensate for its intrinsic biomechanical problems. No idea who said that, but it was probably me. Hopefully that makes sense to you. So we can look at dysfunction in 2 different ways. We can look at the muscle systems used in the movement, screen them to see how they may be impacting upon the movement, which is the intrinsic piece, or we can do the extrinsic, look at the movements to give us a clues to the biomechanics. We're obviously going to go for the first one. Find out why the movement is incorrect before trying to change it. If you see me playing golf, I look more like that than I do in the other side. So we're going to look at a high handicap golfer now. For those who play golf, fabulous. So those of us that don't play, there is something called a swing plane. And the swing plane is between these 2 panes of glass, more or less. There's different coaches will take different things. But basically, the golf club should go up and down, basically between those 2 planes of glass. If it goes higher than that, it's outside the line being here, or if it goes inside of that, it's a low swing plane and it's inside the line. But basically, you want to be swinging up and down in the middle there. So you go to a coach, that's basically what you try and get into. Extrinsically, that is correct. Now we have three of the best golfers in the world here. Inside the line, on line, outside the line. They represented America in the Ryder Cup. That's why we were beaten, because they got British golfers. But there is no norm when it comes to any particular movement pattern. We spoke about that earlier. Everybody has an individual movement sequence. This is how it should look, something like this. This is Luke Donald, one of our better players, played the Ryder Cup a few times. So it should come back up, and if you can see down here, is more or less on plane. So it should look something like that. I was going to take a video of me, but I figured you know this guy better. So that's Luke and how he hits the golf ball. The key biomechanical abilities in golf that we have found, and this is something that we're using on the European Tour. I work with these guys and some of the players. Muscle spasm, key influencer, nerve tension, inflexibility or spasm in the hip muscles, as you can imagine, weakness of hip abductors, limited hip rotation and core stability. Those are the key things that seem to be affecting what's going on with the golf swing. We also have immobile thoracic spine, and we also have pelvic rotation and leg discrepancies. Key things that will affect the movement pattern. And of course you could use those for anything outside of golf as well in this case. So, quick anatomy, range of the thoracic spine. You can see across the top there we've got the flexion, extension, side bending and rotation. We've got the different joints in the thoracic spine down here. But as you can see, down the bottom, we've added it up for you, and most of the movement coming out of the thoracic spine is rotation. A lot of that comes from C71, but a lot of it is rotation. So if the thoracic spine is compromised and limited in range, inevitably it's going to impact on a rotation sport, like golf. This is a high handicapper that I saw. These were his biomechanical results. You can see his predominant left shoulder. Thoracics was stiff as a board. I thought he got any stage ring of autis. We've got left side of the pelvis is dominant and left knee. So that's how he was presenting. And this is how he looked when he swung a golf club. I don't know whether you know anything about golf, but that's not very good. If we were just to slow that down, when you take the golf club back, come on, you can do it. If you look at his shoulder line, that's about as much as he can go. And what should happen is that shoulder should be underneath his chin, and that shoulder should be behind his head. But his angle is about here. It should be here. So this guy had a typical compensation pattern on his golf swing in that he sliced it, which basically means the ball starts left, goes quite a way left, and then if you're very lucky, comes back into the middle again. So that's how he presented. And then when he came down, he did all of this stuff with some horrible chicken wings going on just here with that left elbow bent, for those of you that play golf. But fundamentally, the problem arises because he can't move his thoracic spine. So we spent a bit of time with this guy. We went through the different exercises. We sorted his pelvis out with all the stuff that you know. We started to work on his thoracic spine. 3 weeks later, 2 weeks later, he's swinging like this. Even if you're not a golfer, you can see the difference, right? Let's do it again. He's not quite got the full shoulder turn, but he's a whole lot closer. Yeah? So that's one example of the impact that just doing some real simple biomechanics stuff can have on something like this. He's not an elite sportsman, of course. So what that means in terms of limited thoracic rotation is limited rotation, side flexion, extension. Rotation tends to link with all of those. And then the impact on the golf swing, it impacts upon all of these different things. And when you get the notes later, you can go through that in some more detail. So, we'll know about the pelvis. Another high handicapper, this particular chap, predominant biomechanical features on his right shoulder, left QL, right pelvis. But the key thing here, his right leg is 2 centimeters longer. Almost all of that was as a consequence of the right side of his pelvis being dysfunctional. Now this guy, I'll just play it at normal speed. shocking swing. But let's just have a little look at this guy, break it down a little bit. So his problem is with his right lower back. So his lumbar spine was stiff on the right side, and that's where he was getting his pain. So when this guy takes the golf club back, what I'm going to ask you to do is look at his left hip. Look at his left belt buckle. See how it drops down? That shouldn't happen. Why might that belt buckle drop down? What's he trying to do? Pardon? Yeah, that's what he's trying to do. Unfortunately, his right leg is longer. So he's kind of got it the wrong way around. But notice as the left hip drops, his spine curves to the left as we're looking, to the right as we're looking to his left. So what happens is, the left side of the pelvis drops, and his spine side bends to his left. So he's trying like mad to gap the lumbar facet joints on that right side, trying to reduce the load on that. And then he comes through and he just he went to see the golf coach. The golf coach is saying to him, you've got that all wrong. You're not supposed to be doing this. You're not supposed to be doing this and coming down. You're supposed to be coming into here. So he starts to do that. His back pain increases. Why does his back pain increase? Because his right leg is longer, compresses the facet joints on this side. You then go and rotate when you're grinding those facet joints more. Of course it's going to get worse. It's a fundamental problem. Identify what the problem is, why the movement pattern is as it is, before we try and fix the movement pattern. I've got time for one more example. So, with a leg length discrepancy, if the right leg is longer, these are the type of compensations you get with the golf swing. If the left leg is longer, these are the type of compensations you get. We're not going to go into detail on that. When you get the notes, have a look at it and you'll be able to figure it out for yourselves. So a young girl called Robin Armstrong, and I've got to be very careful what I say. I must be really nice to have others in the audience. As you can see, she's pretty good. European champion, under 18 at this particular rowing event. This is the girl who we've been working with, Robin Armstrong. She came to see us with a back problem, and biomechanically she presented right side dominant, left QL, right side of the pelvis dominant, and right knee dominant. So a typical mechanical presentation. When we saw her row, she rowed like this. Now you don't have to be a genius in understanding rowing technique to realise there's a problem on that left side. See that? So this is all well and good, but actually when we looked at it biomechanically, the problems were all on the right side. The only problem she had with the left side was a hip rotation. I say the only problem. It was quite a profound problem. Anatomically, she had a problem with that left hip, and she could not internally rotate it. It was in a virtually permanent externally rotated position. I don't think she had a full retroversion anatomically because it was able to be corrected. But we were able to correct it to some degree, and then after a considerable amount of time actually, and a lot of hard work on this kid's part, and we just went through the basic biomechanics program, MSAC, we did the pelvis, the spine, the shoulders, the whole thing, and some months later, she was considerably better. Is this girl going to continue to get back problems from time to time? Absolutely. She has a structural problem with her left hip. So she's always going to be fighting that. Doesn't mean to say she's never going to be on a row again. Absolutely not. But if we can deal with the mechanical issues to reduce the load, we've got a chance. We've got a chance. I lie. One more. This is a guy, Anthony Agugu. You've probably never heard of him, but he was a bronze medalist at the 2012 Olympics. You may have heard of him from him poncing about on the Anybody watch this program? I never watch it, but I got a text saying I've got it on Strictly. The following day in the gym, he got slaughtered. So this is a guy who was a boxer at the top of his tree. And when he trained, this is a video of him training. It's only going to be for a moment or two. Extrinsically biomechanically, this guy moves really well. When he stops posing, when he starts boxing now, you'll see that the guy moves really well. He's very quick, very light on his feet. Extrinsically biomechanically, he's in great shape. Great shape. His coach and I were watching this some months ago, and we were really pleased with how he was doing. Extrinsically, he was doing great. intrinsically he was not looking great. Predominance right shoulder, left QL, right pelvis, right knee. He has a history of dislocating his shoulder, right shoulder. You look at something like this and you think, I understand why. I understand why. We've got overuse spasm, infraspinatus, pec minor, median nerve was on fire. We couldn't even, with his wrist extended, he could not depress his shoulder. It was really, really tight. Compromised, I believe, I have no evidence of this, but my belief is that will compromise the velocity with which he can punch. And we're just about to do some tests down at Smith & Nephew lab to actually measure that. So fundamentally, had a problem. So my conversation with him was, mate, you've dislocated your shoulder in the past. Your right shoulder is dysfunctional. Half your muscles are in spasm. You need to fix it. You've got to sort this out. You are at risk. Yeah, don't worry, I'll be fine. I've got problems with my Achilles tendon. That's my big issue. I'm going to have surgery on those, sort them out. I've got my first fight in Germany, which was a month ago, and then I'll sort the shoulder out. Okay, no problem. Just like it. First fight in Germany, what happens? Dislocate the shoulder. Now, can I say that he dislocated the shoulder because of these biomechanics problems? No, I can't. Is it likely that we'd have reduced the risk if we'd improved the function of it? Yeah, probably. Probably. You've got to learn to listen. It's just another example of how the intrinsic biomechanics can affect the sport performance. So hopefully, after all of that,